Good evening, everyone. I, on behalf of the Buddhi Clinic team, have immense pleasure in welcoming one and all of you to our Foundation Day celebrations. I extend a very warm welcome to our esteemed speaker on this occasion, Professor Michael Kerr from the Welsh Centre for Learning Disabilities, Cardiff University. The guest of honor this evening, Mr. Srinivas Acharya, the former Managing Director of Sundaram Home. Our special panelists for the evening, Ms. Saras Bhaskar, a renowned counseling psychologist, and Dr. Kirti Prabhu, consultant psychologist at the Apollo Hospitals. I'd like to quickly take you through the highlights of our journey from the time of inception. What started off as a pilot project 12 years ago as a concept of integrating traditional therapy methods with the modern has grown from strength to strength over the years and has now manifested into a robust and comprehensive treatment paradigm for brain and mind related issues. Buddhi Seva, our CSR activity in partnership with several philanthropists and trusts, has been consistent in its endeavor of making medical treatment available to those who can ill afford treatment. Buddhi on Wheels, yet another novel concept of the founder, has helped take integrated medical therapies to the doorstep of the to those unable to visit us. Necessity is the mother of invention. With many of our clients needing continued care and with COVID posing a threat, Buddhi Clinic launched its integrated therapy kit, the Buddhi DIY kits, enabling clients self-administered treatments in the safety of their own homes. Today, having kept up our promise of restoring optimum life quality, we, as the pioneers of integrated therapy, are proud to have created a seamless blend, the yin and yang of modern science and ancient wisdom, a healthcare paradigm for the future. Thank you.
Thank you, Gayatri. As per the new normal, we are going to have the traditional lamp lighting, but virtual.
Shall we go on? Yeah.
I'm sorry, we will go on to the next program. Thank you for your patience. We invite Dr. E.S. Krishnamurthy, our founder, to release Intellectual Disability, the Buddhi book, detailing our Buddhi Seva learning in the last 1 year. Over to you, Dr. Krishnamurthy.
So it's a great pleasure to be doing this today. The Intellectual Disability Buddhi book really talks about our work in the Kripa Care Home run by Aim for Seva. The cover of the book has been beautifully designed by a joint family, and the contents are there for you to see. Apart from knowledge sharing about intellectual disability and all the challenges, we do have a very detailed documentation of each resident. Next slide, please. This is Swami Dayananda Saraswati, who founded the Aim for Seva Kripa Home. And the slide on the DALIs, the disability adjusted life years, tells you how years of life lived with the disability and years of life lost are both very important. And this figure also tells you how living with disability and disability adjusted life years is prevalent across the world. The next slide, please. The mobile therapy unit you see here is air conditioned and soundproofed, and it takes therapy to the doorstep, the last man on the last mile, and we use it during our projects. This mobile therapy unit and this project was sponsored by the Murugappa Group. There are two companies, TI and Chola, as part of their corporate social responsibility. The figures you see are the Ayurveda naturopathy therapy, treatments that we offer through this mobile therapy unit. Next slide. This is Kripa Care Home. You can see an aerial view and you can see the residents. There are about 40 residents and 29 of them took part in our project, each of them receiving 10 days of 4 treatments each. So 40 treatments in total, of course, free of cost. These are destitute young men whose families cannot care for them, and therefore they are cared for by the home. The next slide, please. This is a typical resident report. Of course, it's anonymized, and the color coding tells you what the conditions are that they suffer from. But the impact, Buddhi therapy impact that you see as a table, it also tells you which symptoms were addressed and what happened. So you can see in this particular case, pain, gastrointestinal symptoms, and mood all improved with therapy. Next slide, please. These were the different diagnoses, and the diagnoses were both medical, neurological, made by Dr. Subbalakshmi Natarajan, who kindly examined all the patients, and Ayurvedic, made by Dr. Agastya, our Ayurvedic physician. And we have also a wonderful amount of work done by Dr. Rama, our clinical director, to compile all this. Next slide, please. We also have valuable information for the caregiver, and we give you a sample here. I'd like to point out that integrative medicine has great potential because it blends modern science with ancient healthcare traditions seamlessly. And we can, through this approach, add years to life and life to years. I'm very happy to present Intellectual Disability, the Buddhi book today. And all of you who would like copies, please do write to us after the program, and we'd be very happy to help you acquire one. Next slide. Thank you so much.
Thank you, Dr. Krishnamurthy. We now call on Dr. Rama Raghu, Clinical Director of Buddhi Clinic, to introduce the DIY kits.
Ma'am, you are on mute.
Good evening, everyone. It's a pleasure to introduce our Buddhi kits, the do-it-yourself integrative therapy kit. Next slide, please. So as the name denotes, this is a kit which the patients will find easy to self-administer. If they are not able to do it, they can have a family member or an attendant helping. And it is meant to mild to moderate symptoms. And it can be done from the comfort and safety of your homes. We have a detailed description of the kit contents and directions enclosed, and we have expert online consultations and reviews scheduled. Next slide, please. So the basic requirements are that you should be able to do it yourself, or you have somebody to help you, and you have a good internet connection to enable the online sessions. Next slide, please. So we have a robust protocol in place. We get consent online from the patient. We introduce the kit, and we follow it up with multidisciplinary assessments and guided therapies, and we monitor the progress and record the outcome. Next slide. So here you can see we have kits for various programs spanning the various disorders. So to quickly take you through it, we have the Respire kit, which is very relevant in these COVID times. So it is meant to improve the airways and lung function. And then we have the Digestio kit, which is meant for digestive issues and focuses on improving bowel movements and reducing inflammation and reflux. Osteo, as the name denotes, is meant to improve, to reduce pain and inflammation, also swelling in joints and improve circulation in varicose veins. And we have neuropsychiatric kits for adults and elders. The brain and mind programs focus on mild and moderate Parkinson's, dementia, and sequelae of stroke and traumatic brain injury. And we have the mind programs focusing on moods and on sleep disorders. And we have special programs for children. And this focuses on autism, ADHD, sleep issues, and other behavioral problems. And finally, we have the Hold kit for lifestyle disorders. Next slide, please. So the program spans 14 days. It's meant to be done every day by the patient. And following a detailed online assessment, we put together integrative therapy programs. So you have a basket of therapies here. So we draw therapies from the CAM lab, and we have ingredients and instructions to facilitate various therapies such as massages and packs, acupressure and inhalation treatments. And from the mobility lab, we have physiotherapy exercises which are taught online. And from the mind lab, we offer behavioral therapies and relaxation exercises. And we offer advice regarding diet, sleep hygiene, and lifestyle modifications from the med lab. Next slide. So here we have two kits. The first kit is the osteo program. So this includes medicated oils and poultices, which are used for fermentation. And we have aroma oils for inhalation, which can also be used while doing acupressure. And then we have mud for abdominal packs and for joints. We have an acupressure jimmy, which is a little stick, which is to be used while doing the acupressure, and a chart which has all the points so that you can identify the points with guidance and do the therapy yourself. We have a detailed information sheet. And the picture below, we have the Respire kit. So this has medicated powders, aroma oils, and then all the bits and bobs which are required to make the therapy easy to do with guidance. So happy to say that we courier our kits within Chennai and outside. And the farthest kit has traveled to a very small village in Maharashtra. And the feedback has been excellent regarding the kit and the outcomes. So to sum it up, this is an earnest effort from the Buddhi Clinic towards bridging the gap in these trying COVID times of distancing. However, we have the niggling physical and mental symptoms that we need to address. So what better way than with a kit which is safe and easy to administer, with the added advantage of expert and supervised guidance from the specialist. So this is a holistic approach to improving and restoring physical and mental health. Thank you very much.
Thank you, Dr. Rama. To introduce the transauricular vagus nerve stimulation, we call on Mr. Vivek Mishra, neuroscientist and enterprise manager of Buddhi Clinic.
Good evening, one and all. So it will be my pleasure to introduce one more modality, neuromodulation modality at Buddhi Clinic. Next slide. So when we quickly overview what is neuromodulation, which is one of the fastest growing areas in medicine, involving many diverse specialty and impacting hundreds of thousands of patients with numerous disorders worldwide. It is the process of inhibition, stimulation, modification, regulation of or therapeutic alteration of activity, electrically or chemically in the central or peripheral or autonomic nervous system. Next slide. So how we evolved about the neuromodulation at Buddhi Clinic. In 2018, we have launched the repetitive transcranial magnetic stimulation. In 2019, we got transcranial direct current stimulation. And I'm very happy, next slide please, to introduce in 2020, it is transcutaneous auricular vagus nerve stimulation. And what we are acquiring is from Sotrix Medical, which is the pioneering device manufacturer from US. And what are the advantages is, unlike the surgically implanted vagus nerve stimulator, TAVNS is an inexpensive, low risk, easy to administer and portable option to modulate the vagus system. TAVNS is appealing as it allows to rapid translation of basic vagus nerve stimulation research and exploring potential treatments of central and peripheral disease. Coming to the TVNS, it is a promising therapeutic tool for a wide range of conditions that shows already encouraging clinical trials. Next. And we look and where we can make an impact. TAVNS is a newer non-invasive VNS, making it accessible for treating pediatric epilepsy, psychiatric disorders like generalized anxiety disorder, chronic pain, and irritable bowel syndrome are debilitating inflammatory disorders that are frequently seen in primary care facilities, but not sufficiently addressed by the classical medical treatment. TAVNS applications are limitless, and where clinical trials are focusing on proteinuria in pediatric patients with idiopathic nephrotic syndrome to sleep disorders, pain syndrome across lifespan, I really think that the TAVNS in our added neuromodulation modality offerings are really going to help in the next generation treatment provisions here at Buddhi Clinic. Next. So I would like to thank our donor, Sundaram Home Finance Limited, for supporting us in this endeavor of bringing cutting-edge neuropsychiatry to people in need and making it more affordable. So I will be very happy if anyone would like to know more about TAVNS offerings, which will be ready to start by Christmas this year. So my email is there, and I will just thank the donors for that. Thank you.
Thank you, Mr. Mishra. We have great pleasure in inviting our guest of honor, Mr. Srinivas Acharya from Sundaram Homes, to address the gathering.
Good evening, ladies and gentlemen. Chief guest of the evening, Professor Mike, Dr. ESK and other dignitaries, Dr. ESK's team and the guests who are watching this program. While all of us are eager to hear Professor Mike, I would just like to mention that the Buddhi Clinic has done some very pioneering work, completely brought a different aspect of medical treatment, reaching out to people. The advancement in medical science has also increased the life expectancy, and we have more people belonging to the geriatric population. Therefore, along with the prosperity, also what has come about is all this geriatric population is having their next generation located far outside in the world. So therefore, their care, attention to their needs has become very necessary. Most of them may not be able to step outside their home. So Buddhi Clinic thought it fit to acquire some ambulances and reach out to the patients, which is, I think, a very novel initiative. Because of the corona outbreak, I think there has been some hesitation on the part of the people to step into the ambulance, which is quite understandable. And so they decided to change over to this vagus neurostimulator, appropriately called TAVNS, which can meet the needs of the hour. And it's one of its, I'm told it's one of its kind in India. So I think it adds an entirely different dimension to the treatments that Buddhi Clinic can offer. But I don't know why you change the ambulance to much better equipment. So why do you need our permission? But that's, I think, Dr. ESK's stress on business ethics, and I thank you for that. I think the Buddhi Clinic may still need an ambulance later on, and I think the Sundaram Home would be very happy to consider your request once again. I wish Dr. ESK, his enterprise, and his team all the best in their service to humanity. I am sure late Krishnamurti, Dr. Krishnamurti Srinivas must be seeing from above and blessing these initiatives. Thank you once again.
Thank you, sir, for your presence and for your gracious offer. We now have Dr. Archana Vignesh, consultant psychiatrist, Buddhi Clinic, to introduce our chairpersons for this evening. Over to you, Archana.
Good evening, everyone. As part of Buddhi Clinic, I take immense privilege in introducing today's chairpersons. Both are women of immense knowledge in their field of choice. First chairperson is Mrs. Saras Bhaskar. She's a renowned counseling psychologist and coach. She has completed her Bachelor's of Arts in Social Sciences in Queen Mary's College, Chennai, her Master of Arts in Applied Psychology in SIT, Chennai, Master of Arts in Human Services, Counseling and Human Resource Management from St. Edward's University, Austin, Texas, and she's awaiting to complete her doctoral thesis. She has around 3 national and 2 international articles to her credit. Over 30 years of experience in all sectors, campus, corporate, NGOs, and in private practice. She is affiliated to the Expat Employee Assistance Program service providing companies like Sheepel, FGI, Global Clinical Services, Canada. And as part of a social responsibility, she is offering free training and counseling to mentors, volunteers, and students of Agaram Foundation, which is a popular NGO. I welcome you, ma'am, on behalf of Buddhi to this academic session.
Thank you.
Next slide. Our second chairperson is Dr. Kirti Pai, who's a well-known clinical psychologist in Chennai. She has done her MPhil in clinical psychology from KMC Manipal and PhD from Madras University. She's a consultant clinical psychologist in Apollo Hospitals, Apollo Children Hospital, and Apollo Shine Hospital. And she's a partner in Element H Psychological Support Services. She's a guest faculty in the Institute of Mental Health, Chennai. She's the joint secretary of Tamil Nadu Association for Clinical Psychologists. She's trained in marine psychology from Denmark in 2011. And she's involved in psychological assessment and therapy for seafarers in Southeast Asia. She's a certified clinical supervisor from the Australian Counselling Academy, Australia. Welcome, ma'am, to this session. Looking forward to a scintillating academic feast. Over to the chairpersons.
Thank you very much. Before Lalita puts up the information about Dr. Michael Kerr, I just want to acknowledge Dr. ESK, who has the out-of-box thinking, who is very creative, ability to produce innovative schemes such as Buddhi on wheels, which is user-friendly at our doorstep. Congratulations and many more anniversaries and wishes for Buddhi Clinic. Now, with regards to the orator today, needless to say that he has addressed us earlier, and thanks for accepting Buddhi's invite to address today's 11th anniversary celebration oration. His present post is he's a professor emeritus of learning disability psychiatry, Department of Psychological Medicine, Cardiff University, honorary professor, School of Medicine, Swansea University, locum consultant in epilepsy and learning disability, locum consultant in epilepsy and learning. I went through his CV and it was about 23 pages. The number of publications are tons and tons, which would be useful for researchers, more so over here. where we are still working on the learning disability, trying to understand the connections between the LD and the neuro wiring aspect of the brain. I now hand over the screen to Professor Kerr. To you, sir.
Thank you. Can you hear me now? Right. I'm going to try and well, it's good early afternoon here and good evening to everybody in Chennai and elsewhere. I hope you can hear me. I'm going to share my screen. There we go. I hope any problems, obviously you'll let me know, but hopefully you can all hear me. This is a view of Cardiff that is so beautiful. No one who comes from Cardiff recognizes it, but it is on the Cardiff Tourist Board website. Thank you, Dr. Krish, for this title, and it's a great honor to speak today to you about such an important issue as keeping the brain and mind well across the lifespan. And I'm going to take a certain angle on this, and I'm going to take an angle that is quite physical, and I'll come to explain why that is. But as we will know from this amazing work of the clinic, everything is connected, and one won't work without the other. I hope you'll find this interesting, and is a reflection on perhaps what is happening in Britain, and nothing as exciting, I think, as is happening in Chennai, but hopefully you will find it interesting. So,
Professor Kerr, before you start, may I add a few more sentences, sir?
Yeah.
You have 40 minutes for your presentation, and it'll be followed by Q&A that'll be moderated by Dr. Kirti Pai and myself. So anyone who wishes to ask, they can post it in the chat, or put up their unmute themselves and ask their questions to you. So thanks for giving me this time to inform the protocol. Over to you, sir.
Yeah, well, no problem at all. It also gave me time to, I think, find how I forward my slides. So that is excellent. Okay, I'm just going to move this down. So I'm honored to be asked to present on the 11th anniversary of the Buddhi Clinic. And I want to give my special thanks to Dr. E.S. Krishnamurti. He has always been a leader in the field of neuropsychiatry, and I was very lucky to work with him when he was leader of the Neuropsychiatry Commission of the International League Against Epilepsy. So it's a great honor to be here, and I have been extremely lucky to have also been in Chennai, which I very much wish I would be now. I also like to thank those who've worked with me to provide this presentation. I'm going to talk a little bit because I want to place how I'm going to look at the mind and brain throughout the lifespan. I want to look at, I'll mention very quickly my influences, which perhaps will explain why I'm going to focus on the physical to improve the mind and brain. But I want to really think about approaching the topic through healthy lives and aiming for a healthy old age. I think this is particularly important in people with disability, and that we so often try and solve a problem in someone of a greater age when in fact the problem should have been solved when they were in their childhood or early adult lives, and it is possibly very difficult to do it at that time. And I'm going to look at various ways that we can approach that. Now, I said I'd talk a little bit very quickly about myself to try and explain why I've taken a perhaps not very mystical approach to this presentation. And what Krish always gives, as somebody else said, he thinks outside the box. So the titles he offers are also outside the box. And I think particularly for me, and I'm going to I'm trying to understand why I'm not as mystical as I think I should be, considering I was only born a couple of miles from that building in the center of your slide, which should have made me take on some of the mysticism from being born in India, but it didn't. Instead, I was brought up in Yorkshire at a very old school there on the left-hand corner, which is most famous for rebellion because Guy Fawkes went to that school. I somehow got touched by epilepsy because I spent my summers at a friend's house, the bottom right-hand corner, which was the childhood house of one of the world's most famous epilepsy neurologists, Hewlings-Jackson, famous for identifying Jacksonian epilepsy. But strangely, in the end, I think the Yorkshire took over where I'm brought up, and it means that there's a little bit of Jeff Boycott in me, which makes me play with a very straight bat. So I'm going to give a very straight bat to today's presentation. And I'm going to talk mainly about people with intellectual disability. I will bring in other areas. By this, I think there are always issues related to a definition, but if we look at this most complicated of population, those with a learning disability, intellectual disability, certainly if we can get it right for the most complicated, we're more likely to get it right. And this is just very much my views with quite a lot of clinical and research experience. First of all, we have to look at aging, the increased needs with age, conditions of old age. We need to look at the individuality and people's perceptions of aging, genetic influence, which I'll talk about to in some degree, and differences in people with an intellectual and with any disability. We have to look at healthy living throughout the lifespan, something which is clearly very prominent in the clinic, and access to healthy lifestyle. And we have to look at treatment across the lifespan, being able to access the best possible public health care and be able to address specific needs of people and reduce treatment-related ill health. And these are all very big issues in people with disability. So we need to think of a lifelong and integrated approach to care. So to look at a lifespan, we need to make sure people get to old age. And that is, we need to deliver high quality health services and mental health services. We need to look at disease identification in people who do not communicate their diseases well or in a manner which is easy for most health professionals. And we need to make sure that we have disease treatments that deal with the complexity of care in people with disability. Again, we need to talk about a healthy life that involves health promotion, accessing health promotion and adapting health promotion. And we've seen in the introduction the fantastic adaptations made by the clinic. And this is what everything is about through disabilities, being able to adapt. And we need to predict health needs so we can look at in advance about what we need to deliver to people. And we need to predict and avoid health breakdown. So promote and plan care throughout life, predict healthy transitions, young to adult and adult to the very elderly. So what are the challenges? The challenges for mental health and physical health and a healthy mind and body is multimorbidity. People with intellectual disability and learning disability will often have a collection of health conditions at the age of 5 that many people wouldn't get to the age of 85. And therefore they have another 80 years to handle their lives with those conditions. So we need to cope with multimorbidity, and the health professionals need to deal with this. Obviously, this implies we need holistic care. We need to be, whilst looking at it as a group, we need to understand the individual and increasingly the individualized genetic impact, which is giving us some insights, first, certainly into physical and mental health development throughout people's lifespan. And we need to look at the quality and complexity of health care because people with a disability do not fit easily into universal healthcare systems. And we've got other challenges in a population who is multi-morbid often, or complex morbidity, is that we have to make sure our treatments are safe and recognize that our treatment impact might be lifelong. This is particularly important in the use of medication. And again, it's good to see such a holistic approach beyond medication and ensuring health promotion. So this is a complicated thing to ensure healthy mind and body and brain across the lifespan. So multimorbidity, this is possibly the most important area. And I think we clearly from the DIY packs, people are very much onto the multimorbidity in this population, offering a bigger mix of areas to deal with. Now, this is a paper which I have to say, I'm going to take issue that the fact that over 55 is old age. And this is a Dutch and German paper. But it looks at multimorbidity in people with a learning disability over the age of 55. It is probably because, unfortunately, they could not find enough people over a higher age who've got an intellectual disability in their populations due to premature mortality. But we can see a high range and high prevalence of physical conditions, dysphagia, osteoporosis, but also neuropsychiatric conditions, but challenging behavior, epilepsy, dementia, almost certainly autism, and probably unrecognized, but anxieties and depressions associated with these. So the people will have, just from 55 onwards, multiple comorbidities. So we have to be holistic in the care delivery to make sure we identify the right conditions and all the conditions to treat and improve. And if we look at a primary care population in terms of some of the neuropsychiatric issues in this population, so this is a UK GP population, 43.6% had possible mental illness of people with adults with intellectual disability. 33% had the triad of social impairments, so autism or a version of autism. 30% communication problems, and a quarter had epilepsy. So the brain has been impacted profoundly across the lifespan by neuropsychiatric disease. So one of the ways to have a healthy mind and healthy brain is to have your health promoted and to try and avoid unnecessary diseases. But this is not necessarily so easy in people who do not access common health promotion systems or do not have the self-advocacy to health promote. And things are also a little bit different. If we look at some of the determinants of ill health in the population of people with intellectual disability, underweight, for instance, is more common. And this is the UK population, which is quite an obese population, but also severe underweight is a common and dangerous factor in this group. But overweight or obese and body mass greater than 25 is higher. And a very interestingly, intellectual disability population in the UK is the ratio to male to female is crossed, whereby there's a very much higher rate of obesity in females. And there's a very high rate of greater than 30 body mass index. And this, of course, has almost undoubtedly led to the problems we have had with mortality in this population, as this is such a risk factor for mortality in COVID. And again, is presented by the high risk of diabetes. So these are all lifetime risk factors which will shorten and diminish the quality of life, lead to neuropsychiatric and health disorders over time, particularly dementia, and needs addressing. However, it is not such a simple story, because this population, in the UK population, also has a smaller rate of some of the other determinants of ill health, such as smoking in particular, and alcohol excessive use, which is a very prevalent issue in the United Kingdom. So there's two sides to the coin. And how you uptake your health promotion is affected by how severe your disability is and the nature of your disability. So issues like cervical psychology for cancer of the cervix is very unlikely to be done in people with a low IQ. Mammograms, again, unlikely. Yet some issues like immunizations are slightly higher, maybe because the people can't disagree with having them. So we have to very much individualize our health promotion for the person's individual needs. An increasing impact and a very powerful issue, certainly in the United Kingdom now, for young children identified with disabilities and impairments, is trying to understand the lifelong effect, mental and physical, of the individualized genetic impact. Some of this has been known for a long time, but other work is just in progress. So let's have a look at, for instance, the classically used genetic syndrome associated disability, which is Down syndrome. But as we can see from this slide, the needs of the population alters by their age in terms of developing their mental and physical health. So from 0 to 18, the population of Down syndrome has very significant issues with cardiac problems, particularly in the first few years of life, respiratory problems, leukemia, epilepsy. Yet in their younger adult lives, depression becomes a very significant issue, low thyroid, poor access to health promotion, including weight gain, and epilepsy again. And then over 55, a very significant issue arises of very high rates of Alzheimer's disease, associated with that, new onset epilepsy, continued problems with thyroid disease, and significant problems to depression, sometimes mimicking the cognitive impairment of the Alzheimer's. So when we're planning mind, body, and brain across the lifespan, we have to plan for recognizing how individuals can predictively have different needs across time. If we look at the condition Rett syndrome, for those who do not know this condition, it is the commonest cause of profound learning disability in girls. It is a single gene abnormality of the MECP2 gene and leads to very profound learning disability in girls and very rarely anything other than death in boys, although there are boys with Rett syndrome. It has a very specific profile of health needs, lifelong health needs, to do with scoliosis, epilepsy, mobility, nutrition, and then interestingly, when you come to adult life, depression and neuropsychiatric problems, behavior problems become common. And at the moment, we don't really know that much about the impact of aging over 55 because we are not identifying this population. There are people who are over 55 with Rett's, but we're just going to learn about this population, and a whole new population and population needs will become obvious to us. And if we go to the field of epilepsy, we have Dravets syndrome, a very severe childhood epilepsy associated with severe learning disability in most cases, reaches the headlines now because both a dietary approach, the ketogenic diet, and the use of cannabinoids can be used for the epilepsy and Dravet syndrome. But from 0 to 18, there's a very profound epilepsy, significant cognitive issues, and motor decline. And we're unfortunately seeing that cognitive and motor decline is presenting at this early age of 19 to 55. So our holistic care has to recognize the cognitive need in this population so much earlier. And these are 3 conditions, and there are, of course, probably over 300 conditions with for whom we don't know yet the specific future genetic impact. So how do we begin to address that? Well, it comes to trying to address the quality and complexity of healthcare, holistic, multi-professional, recognizing needs, and equal care for people who are not equal often in society. Unfortunately, in the United Kingdom, we have not done this particularly well. We do record at least how badly we are doing, but we don't do this particularly well. We have a confidential inquiry into deaths of people with learning disability, intellectual disability. And of those who died in this inquiry, 97% had one or more long-term treatable condition. And epilepsy was specifically common. Tardive dementia was common. Issues came out that have to be addressed, that people with disabilities experience difficulties in the diagnosis of treatment of the illness compared to comparative groups. Diagnosis is delayed, treatment is less. All aspects of care provision, planning, coordination, documentation were significantly less good for people with learning disabilities than for their comparators. So the aim of a healthy mind and brain is actually an aim of reaching equality at the beginning for a group who have already got more profound problems, but they don't even reach equality with those with less problems, at least in the United Kingdom. If we look at this quite complicated slide, but this looks at all admissions to hospitals in England for the over 65s for bed days, and the group in yellow are people with learning disability, and these are for admissions that are potentially preventable. So they're called ambulatory care sensitive conditions. So these are conditions where if treatment was good, you would be more likely to stop an admission. And as we can see, epilepsy in the blue oblong boxes I've made. So convulsions, the yellow line is highly greater than that for the non-learning disabled population. And for other ones, it is not, constipation is higher, but other conditions such as COPD was much lower, angina was much lower. And this may be due to the less smoking, but it may be due to poor recognition of the condition. So we also have to adapt to the needs. So if we're looking at particularly epilepsy as a particular need in this population. So as I mentioned before, when people have complex neuropsychiatric disorder, which people with learning disability often do, there is a strong possibility that there will be treatment, lifelong treatment for this. And this, of course, is necessary for many, many people, but we also need to recognize the impact and make sure our health promotion affects this. So in the United Kingdom, long-term antipsychotic medication is particularly common in this population due to often complex behaviors and anxieties associated with autism. But it has an impact which, particularly when it's given from an early childhood age, needs to be factored in or at least mitigated against by better health promotion. So obesity, diabetes, mobility problems, increased risk of arrhythmia, increased risk of stroke, and increased mortality. In Wales, when we look at our all Wales prescribing population for the population of people with a learning disability, sorry to remove this box here, we get a very high percentage of people who are on antipsychotic medication across Wales who have a learning disability, and it's particularly high with people with autism, and particularly high if you're in a special school. So I'm not certainly saying this is not indicated, but it does not always or ever, I think, be prescribed in association with attempts to improve a person's healthy body to help their healthy mind. So in terms of health promotion. And it is important to note the evidence around these medications. So the best quality randomized placebo-controlled trial, and this is from Tyra et al. In the Lancet, and this is non-psychotic use of antipsychotics for aggression. And essentially, the tool used to look at aggression showed that the aggression improved most in a 12-week period when you're given a placebo compared to given the risperidone. So this is a particular use of risperidone or haloperidol, which is for aggression, and it's often used for anxiety, which is a very different use and may well have very different findings. But we have a population who have emotional and brain needs, which we give drugs to, and we have to recognize the lifetime impact of these medications. So what are the solutions to a population that has complex psychological issues associated and very strongly associated with learning problems and strongly associated with physical health and a treatment gap, a mortality gap and a morbidity gap? And this is very difficult. And I think we look for local solutions, and we clearly see that in the multi-professional approach and multi-modality of treatment approach of this clinic. But this is not necessarily the approach that most people get the chance of experiencing who have a learning problem. Well, we need to have services that are empowered for the person with a disability. They need to fit that person's needs, which are often highly impacted upon by communication and other quality of life measures. We need to support carers, and carers need to be informed, supported, and active in healthcare. Carers have a burden, and that burden is reducing. And as our esteemed guest of honor quite rightly identified, the pattern and what means of care delivery has altered as society's changed. And carers always used to be informed family members, and now we have informed and skilled non-family members who cannot, of course, know the person's life history in the same way that a family member can. So we have to support the delivery of knowledge about some person's health to those who care for the person. We also need to make sure our general healthcare is good, that can identify disease, treat common diseases, psychological and physical. And we need hospitals that can treat people with respect. This may not, I'm sure it's not an issue in India, but in the United Kingdom, we have a lot of issues with people with disability being treated poorly in hospitals, getting poor treatment. And we've had some national scandals on this. People need to be able to access the special care they need because the problem is multifactorial. It is not enough to say one size fits all. And policy and government need to support this because it comes at a cost and a recognition that the one size fits all, which is very much the way things are looked at often in the United Kingdom. So, as I say, so firstly, we need to have a delivery of general health that can make sure people get their general health treated and their common disease treated. So I in Cardiff in the early 90s designed something called the Cardiff Welsh Health Check. And you can see the information that goes out to the person with a disability. That's in Welsh, if you on the one on the left or my left, and this is the one on the right is in English. And basically every year, adults with an intellectual disability, often in England from 16 upwards, have a health check, a full physical health check with also questions about mental health, behavioral change, looking for issues of psychological change and mental health. These studies have been shown to, this intervention has been shown to work and is given by the GP and the practice team and is given annually, and there's over 100,000 per year given in the United Kingdom. It's not patented or anything, not copyrighted, so it's free, although government pays the GPs for doing this. What these checks do, this is from a government group looking at this, and the health checks, they diagnose unmet need in people who are not good at recognizing their conditions and communicating them, which is people with an intellectual disability. And they allow targeted address of health needs. And they've also allowed people to get regular contact with general practitioners to look at a positive way in their health rather than just dealing with the crises. So the conclusion is that is to assist in the identification of treatable morbidity and make sure people get the same health gain as the general population get. And it is a systems approach to dealing with a problem about delivery of healthcare. It is what we would call a reasonable adjustment in the United Kingdom to change our treat healthcare reasonably. There are some papers, a paper in Lancet Psychiatry showing that people who access this get a very high level of increased referrals, medication reviews, action plans, treatment of gastrointestinal disorders, identifying obesity. So it works to identify needs in people who previously have them, and as an adaptation to get a healthy mind, body, and a brain across the lifespan. Everything has dropped a little bit. It was 86,000 done in the United Kingdom, in England in 2002. Essentially about half the people who should be getting this are getting this. And this has been, I'm going to move on a little bit quickly, but this is a very complicated slide. But one of the things we do have is a lot of numbers in Britain. And this is a map looking at the uptake across different countries, percentage, and showing the variation from low variation to high variation in the percentage uptake. So even a national mandated policy to try and improve care will show great heterogeneity and variability across a country. Okay, and in Wales, we can see here a great percentage difference. We range from 63% in one area of Wales, this I believe was the north of Wales, down to 12% in an area of Wales. And this variation is not actually is not from deprivation. There's no impact of deprivation on this. It is just individual practice by individual general practitioners. Okay, so specialist healthcare able to manage the special health needs emotional and otherwise, of people with a learning disability. So this is, we come to models of care here, and specialism around complex specialist care such as epilepsy that is able to integrate with generic services and using the multidisciplinary team. So I'm not giving a talk on epilepsy here, so I'm not going to talk about the complexity of epilepsy, but I'm going to talk about the importance of teams, really, and that this population needs teams, because a person with a psychological or other problem with a learning disability will have that in the context of multiple needs. There may be educational needs, there may be care needs, physical needs, and for one individual to provide it all is asking a little bit too much, and we need to work in teams. So there is quite a lot of research on the importance of multidisciplinary teams in medical contexts. For example, mild brain injury, there's strong evidence that teams help make a good recovery, appropriate information, strong evidence for moderate to severe injury, from formal intervention to severe ABI already in rehabilitation. So there is evidence out there that teams work, and teams is the answer to this population. In nursing, work is going on trying to verify the roles, the impact of specialist nursing in epilepsy. There's no one who experiences it who doesn't think it's a good thing. It's just that there's no funding body that gives enough money to do the trial that will show it. We do work in complex teams. In learning disability, we work in teams specifically involving psychologists, psychiatrists, nurses, occupational therapists, physiotherapists, and obviously carers, because you realize that to get an outcome in complex disease with learning disability, you need to take many angles at the same time. One key area in the population of people with learning problems, and particularly those with intellectual disability, is support for managing behavior and behavior change. There are trials on this which show that treatment plus applied behavioral analysis performed by psychologists and teams have an impact through using specialist behavior teams, and they reduce the overall score on the aberrant behavior checklist in population. So we know we do need to approach it a lifetime with a team approach, of multi-professional team approach. So we've talked a little bit about how care can be delivered, and it's in keeping, I think, with the models delivered in Chennai. And with all this, we also need to make sure that the center of this is the person and the carers. So we need a person with disability to be empowered, and carers informed, supported, and active in their healthcare. So I'm going to go back to Rett UK, because I for many years ran a national, worked with two other consultants running a national Rett clinic. And the charities in the UK have taken the lead in developing tools to support individuals and families, because girls with Rett very rarely have the community. They do exist, but very rarely have the communication skills to communicate their own health. We need to work with the families to communicate their health, and they've introduced best practice guidelines in epilepsy, carers information, GP health checks, GP role in the care. And this is apart from a document on the GP role in the care of Rett syndrome. It's advising GPs about the fact the child may have feeding problems, the sort of advice who to refer to, may have mobility problems, may have spinal problems. There's also advice on depression, because depression is increasingly recognized in this population. So there's a whole range of these. The Down Syndrome Society does these as well, and I'm sure you have versions available in India as well. Hospitals that can treat people with respect. This sounds very negative, but unfortunately it happens in the United Kingdom. Well, there's no easy solutions. We now have learning disability nurses within hospitals to educate hospitals. We have packs on every ward to talk about communication. There is a thing called the traffic light system to identify a person's needs. And essentially this needs to be worked on. But I think this may be a UK cultural thing that is not a positive thing. I'm not going to say anything about this. We saw some previous issues of measuring healthcare On a national level, if you're going to change health and mental health care over a lifespan for people with disability, you need to show you're actually doing it. And to do that, you need to measure it. We've seen that the data on hospital admissions, which tells us some measurements, and we've seen the national inquiry. We are working with, in Swansea University, we're working with large national data sets to look at ways of measuring. We're measuring drug use over time. We're looking at mortality for sudden death and other ways of measuring healthcare. This is also important. So I've come to an end a little bit early, but this is the trouble about speaking to a computer. It's a massive topic, and I stand in awe of those who deliver the broader holistic care of mind. Supporting mind and body is a lifelong process, and being lifelong means you will have better aging and a better life. And it is about understanding complexity and about recognizing how you get an ordinary life in the context of this complexity. It's enhanced by understanding the health needs, providing healthy lives and healthcare interventions. But I think most powerfully, without such care, people will suffer lives lost and lives ruined. Thank you very much.
Thank you, sir, for the extensive talk on how LD has been treated and managed through UK. Sir, may I request you to stop screen share so that we can, thank you, sir.
Yeah, I just lost it then.
Yes, we've done that, sir.
You've done it, okay.
Thank you, sir. So, if I may start with a question, I would want to know if there were any gender differences, if you have noticed any gender differences in the neuropsychiatric aspects associated with LD.
That's a good question. The answer is no, but I once wrote a chapter in a book on women's health in LD, and my chapter was on men, and it was titled "The female of the species is more healthy than the male." Mm-hmm. And in general, it is the male who tends to work. But of course, we don't have I think we're not very good at diagnosing depression and anxiety, which would be a gender difference issue. We are missing those very negative male impacts, such as alcohol, brain trauma, and this sort of thing. There's always an issue that's slightly more males because of X-linked conditions. But I've no doubt they are there, but we're probably curtailed a bit by we don't have as much puerperal conditions. Yes, I'd have no doubt they would be there.
I agree with that, sir, because even in India, I'm sure, there are gender differences, may not be as well noticed and as well documented like a country like UK.
I suppose one of the classic neuropsychiatric gender differences is in non-epileptic attack disorder. And I would say possibly that still is the case, that there are more females who have that, but not as pronounced a situation. I think we realize that that is a powerful impactor on that is very poor early life experiences. And I think both men and women in the LD population get very bad early childhood life experiences.
Very true, sir.
So, but I would have to bow to others' knowledge on that.
Very true, sir. So I also would like to add here that in India, women are allowed to have kind of conversion symptoms because many places like places of worship, possession attacks, and are allowed, in courts. Yeah. Okay. So more like a coping mechanism here.
Well, I think that's over-medicalization is not necessarily a great approach to conversion. So I think it's a very good thing.
Exactly, sir. Ma'am?
Professor Kerr, Dr. ESK has a question. As an international expert on disability, which health system and countries do you believe is best set up to care for people with intellectual disability as they get older?
I think I'm probably not. I think I'd have to be an international expert in social care delivery, because I suspect it all comes down to the social care. I think, yes, I think it's such a difficult question. I generally don't know. I can think of some I think may not be very successful, which I suspect the United States would be not so good, because I think if you've got a non-socialized health, what they would call a socialized healthcare, is a negative thing, but we have a socialized healthcare. I think without holistic healthcare, from people who are likely to have had a high income throughout their lives, are going to be in a very difficult situation. And so any nation like that, in a lot of nations, the problem is not getting to old age. And I personally, I've been somebody who's hugely committed to families, as so much of my work is families. I think anywhere where your family stays together as long as possible, it's probably much more important than what your government's doing. Very difficult question. I think there'll be a lot of individual, but if you don't get your healthcare, you won't get there. So if you haven't got a healthcare, it'll be healthy survivors who get there, which has been the issue for many, many years. We have healthy survivors.
So is that we need to understand that it's not just the family care, but also the system care, the health care, like a wraparound services that is going to help the intellectual disabled one as they get older. So it's again, it's a wraparound services from one and all who are treating.
I mean, the evidence always shows that people with intellectual or mental disability will always get access care less. And so it's all about what adjustments your system makes. And a lot of systems will only get adjusted with the stick plus carrot, so they'll need some sort of encouragement to try and get access to people who are on the edge of, these are the people who are, on the edge of the light. Some of these people, they're right on the edges of society, and we need to try and find them and support them. So the default is not to get care for most health systems unless you're pulled into them. And if you're in Medicaid, Medicare, for instance, to access that is very much more difficult, and particularly if you're someone with an intellectual disability.
Kirti, is it okay if I ask a question to Dr. ESK? Okay. Dr. ESK, I have a question for you. With the launch of this TAVNS, you have also mentioned depression, that the stimulation can be worked with the depression patients. Can you give a scientific connection between the stimulation and the depression, sir?
I think the vagus nerve, as we know, is probably the part that connects our autonomic nervous system with the brain. And the connections are in the limbic system, which is the oldest part of the human brain and the seat of our emotions. VNS by itself as a treatment for epilepsy and depression has been around for a long time, and they used to put the stimulator into the patient. Vivek will probably be able to tell us how they've come up with the idea that they are able to stimulate the pinna and thereby stimulate the vagus nerve. Vivek, do you want to say?
So like even in the TAVNS, so it is sometimes the current clinical trials are also stimulating the two electrodes, simultaneously stimulating the VNS system. And so it is what we are using is the auricular branch of the VNS, what we are looking for. But most of the research which comes is when we are stimulating the vagus nerve, and there are the brain regions like the left interior insula, and it is been getting excited on the fMRI studies. And with the activation of the insula, we are looking for that their depression symptoms are getting elevated, and I think that's the thing. But yeah, like the application, there are still multiple clinical trials are going on, especially in refractory epilepsy, where we can use it early on in the life, above like around like, so the surgical one we have to wait 12 years and over, and with,
okay.
So
so that's
it's actually a clever take on what used to be a surgical treatment. It's a clever take on that by using a non-invasive way of stimulating one branch of the vagus nerve and thereby influencing the actions of the vagus nerve.
Amazing.
And you will then get effects on these conditions that Vivek was talking about.
So how many sessions one has to go through, Dr. ESK or Vivek, whoever wants to answer?
Like there are current trials what I am in touch with. So what they say is some of the stimulation it takes like for 5 to 10 minutes for over 3 months. So that is one of the recent trial which just got published on the like clinical trials website. But yeah, I think it should be around 30 plus sessions of 10
Okay.
which have to be delivered.
Every day, or that is determined based on the intensity of the depression?
Like again, it differs from if we totally talk about the depression, again, it will be like every day. It's just like if we talk about the TDCS also, what we are doing, we have to do 6 times a week for 4 weeks. So I think it's be saying, but for epilepsy, it is definitely a more consistent thing.
Thank you, Dr. Vivek. Over to you, Kirti.
I would also want to add here that, you know, with the transvaginal stimulation is also helpful with patients having trauma. And there's a lot of research evidence based on that. Indeed, I'm really thankful to Dr. ESK for bringing it here and, you know, providing it cheap, because, you know, I think patients with trauma would definitely be helped, you know, with non-invasive aspects like this. So it's indeed a, you know, heartwarming approach that we are reaching to the masses, and people would definitely would want to come in and take this as a health inspiring aspect. Yes. Over to you, sir, Professor Mike. There is a question from the audience. This is from Mr. Srinivasa Murthy. In supporting caregivers, what has been the role of spiritual support? So he would want you to answer about the role of spirituality in caregivers.
Right. I think I can genuinely say that is not a speciality of mine, but I would obviously, I would obviously, you know, support it. I mean, the issue we have is, I think, you know, is almost before that is a recognition that caregivers are a group that need it all, and that when we can recognize their importance, then obviously for each individual, whatever their lines of support are is important. So I mean, I would strongly support it. I mean, we have very, very I think very diverse spiritual needs in our populations of caregivers. We're not the families, well, perhaps families, you know, Cardiff is a very multi-ethnic city. So I mean, I'd be, you know, wholly positive about it. I mean, I've had patients where someone from the mosque has come along with them, and I've had patients where I've talked to, you know, people from the church. So it all depends on the person. So you know, it's obviously a very important area. It's about having the time to work out where the caregiver needs their help from. And we did a study on where you would get help from for people who had epilepsy, who were depressed, and we asked people who were with epilepsy or depressed where they would get their help from if they were depressed, you know, and it ranged from their spiritual person to their best friends, to their mother, to nobody, and it was interesting in its range really about where people would gather. Fortunately, most of them didn't seem to want to go to Google, but maybe that would have changed now. But everybody's got, I mean, I think when you're looking for when you look for support, it's quite an individualized thing, and it's something which you do probably related to everything you want support from. So it's about accessing that. And I think a recognition that if people are going to their spiritual advisors, a dialogue with that spiritual advisor may well be important for the professional if there's perhaps a difference of opinion or a difference of clarification needed.
Thank you, Professor Kerr. I have one question for you from a participant. How do we manage repetitive head hitting, self-injurious, limb biting, challenging behavior in adults with intellectual disability? Preferred medications?
Okay, well, obviously what would happen in the United Kingdom, I think, would be that is almost certainly that adult would have had that problem since childhood. That pattern, well, I think that pattern of behavior would be, if that was appearing new in adulthood, you would be looking for a remedial cause, I think, first of all, to ensure there wasn't a physical illness, neuropsychiatric illness, psychological illness going on, because a lot of people who self-injure have that as a pattern of behavior throughout their lives, and it just alters with often unknowable reasons, but sometimes physical health, sometimes emotional health, sometimes a change of care, provision, emotional change, bereavement, all these things. So you need a very holistic assessment to make sure you're covering all the options. You need to look at that individual's level of disability, what they got autistic traits. So, I mean, self-injurious behavior is very, very rarely caused by epilepsy, but it's normally a developmental issue related to your cognitive state, and it's usually assessed as a communication, first of all, and then
absolutely
how do you try, and I think it's not as simple as that sometimes, because I think sometimes it is also so girls with Rett syndrome, for instance, bite their hands all the time. I was a co-supervisor for a PhD project which looked at direct observation of this, and it really was not something that was very related to the environment. It was an inherent thing. The person was biting themselves, and there was some improvement by changing the communication and trying to change the emotion around them. So you have to take it. So it's everything from looking for obvious causes to trying to distraction. So try and put an alternative behavior in the place. But we have a very amazing charity in Cardiff called the Touch Trust, who use touch as a therapy. And one of my patients I had, it was the most terrible self-injurious person. She would hit her head against the table constantly, and they got through to her, but it took about 4 years. So I think when you get something like this, your goal has to be very not like it would be for, say, you or I. It's, this might take tiny steps of a fantastic quality environment, trying to give everything. And medication may or may not have to be given. The only thing about medication is that don't keep it going if it hasn't worked.
True.
Most of the problem that comes from antipsychotics is them not being taken away when they're obviously not working. So the person's exactly the same. People are frightened of taking it away in case they're actually worse. So yeah, it's a very slow, a lovely environment. I mean, I think I'm very much believe in the environment, a high quality environment, high quality communication, and a lot of time.
I believe you nailed it. The holistic assessment is what is going to determine, the communication pattern, or, their moods and other things. Excellent. Thank you, sir. Over to you, Kirti.
Kirti, can I just share something?
Yes, sir.
So we have, just to take on the point that Professor Kerr made about people having new onset challenging behavior. So as Professor was pointing out, if the behaviors lasted forever, that's a different ball game. If it's new onset, then one of the things I do recommend is a kind of a biopsychosocial approach. Some of our patients, for example, have turned up with things like thyroiditis, Hashimoto's disease, which has resulted in a sudden change in behavior. And we can't assume, therefore, it's just some behavior coming on in someone who is intellectually disabled. One needs to look for a medical or a neurological cause as well. That's one. The psychological aspects, sometimes it is subtle changes in the environment, like a new person who's come into the household, and it's considered so innocuous that no one will mention it to you. But so you have to ask for changes in the household, changes in the environment, changes in the school or the place they go to for their rehabilitation or their vocational training. Often those things exist. And of course, other things like grief, that even the death of a pet, death of a family member, they affect the patients too. So in a sense, therefore, one needs to look at that. And just the point about touch, I wanted to say that one very interesting observation we've had in working with autism, in working with dementia, in working with intellectually disabled, is that there is this Ayurvedic head massage called Shiro Abhyangam. And it involves, having hot, warm oil poured on your forehead, and then you have a massage of the head and the neck. And in the initial 1 or 2 sessions, people actually have to be helped to have that. But many of them start seeking it repetitively thereafter. They love the stimulation of the warm oil and the massage. And when they come into the clinic, they go straight to that room rather than anywhere else. So I just wanted to point out that touch has a huge role to play as well.
Absolutely. Thank you so much.
Can I add something to that? I think Dr. Krish, first of all, there is a paper by a colleague of mine, Professor Hastings, which shows life events being associated with challenging behavior in adults, the new onset challenging behavior. But Krish has raised, I think, the really important issue of what we call diagnostic overshadowing, which is basically bad diagnosis, but it's jumping to conclusions because you have an expectation. So you see a person with intellectual disability and you think, well, their behavior must be because they've got an intellectual disability. They see a person who's immobile and you think they must always have been immobile because they've got an intellectual disability, when in fact they've fractured their leg or something. So it's that open mind, thinking outside the box, that makes a difference for this population. High quality, the highest quality medicine always with the adaptation.
Absolutely, sir. So there's a question from a participant. Could epilepsy have a component of a viral infection in the brain? Can viral infection such as chickenpox be playing a role in the absence of antibodies?
Well, there are definitely, encephalitis will certainly cause seizures, and a small but a significant proportion of people we see with very difficult epilepsy disability have had herpes simplex encephalitis as a child. There is a whole range of autoimmune encephalitis, which is when you attack yourself with your immune system, causing encephalitis, NMDA, and other receptors, which seizures and confusion is the presenting symptom. And then there's a lot of research looking at autoimmune antibodies in people with ongoing seizure disorder. And I think it's got much more confusing over time. But the answer is yes, epilepsy. But obviously it's for the individual. So new onset epilepsy with certain sorts of seizures, particularly strange mouth movements, but with confusion, temperature, they'll often end in intensive care. Autoimmune is also associated with psychosis, so with new onset psychosis as well. So, it's there amongst everything else. I mean, these are often a final, epilepsy itself is a final common pathway. There's many things can cause it, and the final result is a seizure, which infection is one of those things. Your genetic tendency, your nutrition, your mood, all sorts of things impact on it.
Thank you, Dr. Kerr. As we are getting closer to the end of this excellent informative session, one last question that I would ask of you, Professor Kerr. It is from the participant. The UNCRPD and more general awareness is enabling attitudinal change towards persons with disabilities in India. How is it in Wales?
Well, I think we've got some very strict laws about disability discrimination, which have been powerful drivers, and there is the most powerful drivers. So I don't think we are necessarily responding directly to the UN situation. We're more responding to our Disability Discrimination Act, which is very powerful, which is obviously, works off that, and signing up to the UN Convention, Human Rights, and so this is not, it's not the world which even I grew up in. It's certainly not the world when I interview new medical students, their approach to disability and all is just fantastic. And they almost always, they've had people at school with them with disability, and they've just got a completely different view so I think there is a very positive. It just, sometimes people seem to get a bit worse when they get older, unfortunately, but certainly when they're young new medical students, they come in with some very positive ideas. So, and it's the law and the UN, and these are the powerful movers. The problem with it has been sometimes people have felt that the anti-discrimination meant that trying to deliver special approaches to healthcare was discriminatory. And of course it could be if it was based on discriminatory, but it's not. It's adaptation to complex needs. And I think that can be sometimes maybe even used by health funders as a reason not to support more complex approaches to disability, to say, well, it's not what the rest of the population get. But the charities are very good for that, because they realize that you need more.
Thank you, Dr. Kerr. Over to you, Chairperson, Dr. ESK.
Thank you, Professor Kerr, and our thanks to our chairpersons. We call on Professor Krishnamurthy for an announcement.
Sorry, I was not unmuting myself. Happy occasions call for happy news being shared. So before I do that, can I get everyone to put their video back on, because Lalita wants a photograph of all the panelists.
Thank you.
Very quickly.
Take a shot.
I hope you've got a shot. I'm very happy to say that the first tech millionaire in the .com boom from my class was a guy called Venki Harinarayan, who went to the US, set up something called Jungly.com, and sold it to Microsoft for a ton of money. And Venki Harinarayan remains a very successful tech investor in the US. And I'm very, very pleased to say we've reconnected, and we've been in touch about various things. And he's made a very generous donation to us. In fact, today, we are going to be able to give a lot of care to about 50 people with various forms of neuropsychiatric disability this year, 50. And the Buddhi Clinic offer we made to the donor, and we make this now to all our donors. Whatever you contribute, we will add 50% from our side in terms of service. So we are looking forward to working this year in a very, very structured way. His particular interest was in helping people with epilepsy, and I'm sure that will warm Mike's heart. So we're going to be working with a group of people with seizures and intellectual disability through the year, thanks to a very generous donation from Venki Harinarayan. And he said he'd be horizontal at this time because it's kind of 6:30 in the morning for him. But he was happy for me to make the announcement. So I'm very pleased to make the announcement on our foundation day. Thank you.
A wonderful gesture from your friend, and which will go a long way towards the patient care. Thank you very much, Dr. Krishnamurthy. For the Thanksgiving, we invite Yuvaraj, Senior Care Manager, HOD Mobility Lab, Buddhi Clinic. Over to you, Yuvaraj.
So it's time for giving thanks. So as we come to the end of this program, it's my pleasure to thank each and everyone for their contribution. First, I'd like to thank Professor Mike Kerr for the wonderful lecture. I thank our honor of guests like Mr. Srinivas Acharya for the generous contribution towards Buddhi Seva. I thank Mrs. Saras Bhaskar and Dr. Kirti Pai for chairing the lecture beautifully. I thank Mrs. Sheila Balaji, Chairperson of Krupa, and Ms. Radhika Sundarajan, Director of Krupa, for their enthusiasm to initiate Buddhi Seva program and for the immense support and hospitality to the Buddhi team right through the program. I thank Dr. Subbulakshmi for all the efforts in getting every minute detail right for the book. I thank Ms. Divya of Joint Family for designing the Krupa book. And I thank Marandeshwara Enterprise for managing this event. Ultimately, I can't miss out. Special thanks to our audience. Once again, thank you all.
Thank you, everyone.
Thank you, ladies and gentlemen. Au revoir. We'll see you soon in our next edition.
Mike, namaste is what Boris is doing. So namaste. See you. Bye.
Congratulations and thank you.